Good evening, friends. Welcome to another edition of IMA Haryana Academic Fiesta. And today we have amongst us Dr. Suresh Vasistha, who had been National President of Association of Surgeons of India. He had been Vice President of Medico-Legal Society of India. And he is very senior, minimally invasive laparoscopic surgeon and Director of Mangalam Hospital, Gurgaon. So, welcome Dr. Suresh Vasistha, and I would request our President, Dr. MP Jain sir, to declare the meeting open and share his pearls of wisdom. Dr. Jain sir.
Thank you, Dr. Pawan, and welcome Dr. Suresh Vasistha.
Thank you.
My best friend, excellent surgeon and medico-legal expert. He's a very good orator also and a very good theatre artist also. But today he will be discussing a very pertinent topic, which is consent. Probably that is the base of all the medical negligence issues or the cases. So he will be he has a lot of practical experience about it. He has handled so many cases also. So today he will tell all of us how to take consent, when to take consent, everything about the consent. So everything has to be done with consent. So I welcome Dr. Suresh Vasistha, and stage is yours, dear.
Thank you. Thank you so very much. At the outset, I thank Haryana IMA, its president, secretary, Dr. Pawan Goyal, and it's so pleasing to see some of very senior friends and my mentor, Dr. Kohli, who has been my guru not only in surgery. I learned laparoscopy from him, and whatever little medical legal knowledge I have, the credit goes to him. So my gratitude and my regards to Dr. Kohli sir, and my friend Kumar, all the executive members and dear friends. सबसे पहले आप सबको दीपावली पर्व की बहुत बहुत शुभकामनाएं, क्योंकि अगले फिएस्टा से पहले आप लोग दीपावली मना चुके होंगे। आप सबको बहुत मंगलमय और शुभ हो। और जहां तक के टॉपिक दिया गया है कंसेंट का, तो कंसेंट में सबसे पहले मुझे बताया डॉक्टर पवन ने कि आप व्हेन बोलेंगे, व्हेन द प्रोसेस शुड स्टार्ट. So consent is one of the most important aspect of the overall treatment process.
Yeah.
Wherein we inform and discuss everything with the patient, and improper consent and faulty documentation, they are the most important two killers, so they are very important two killers which account for nearly 2/3 of the total medical litigations. The concept of kindly mute everybody yourself. The concept of consent evolved after the post-World War II Nuremberg's tribunal and trial, wherein the member countries, they adopted the Nuremberg Code, and henceforth the medical ethics and the consent evolved serially, and where we are today, it is a continuous evolving process. So when it should start? It should start at the time patient thinks of going to a hospital and he walks inside the hospital. The hospital should have enough signages to give him a picture that we are not God. So you can write, this is a temple of healing. Life cannot be guaranteed. Man is mortal. Even the doctors treating your patients are not immortal. Every human being is biologically different. That's why every member of a family have different Aadhaar card, different retinal scan, and their genetic code is different. And behavior of every patient to the treatment differs entirely, which may not be understood by the science as of today. Life is not a purchasable commodity कि मैंने 30 लाख रुपए खर्च कर दिए फिर भी मेरा भाई नहीं बचा. Doctors try to preserve life and alleviate suffering, but results are not always predictable. Human body is the most complex machine in the universe. जातस्य हि ध्रुवो मृत्युर्ध्रुवं जन्म मृतस्य च तस्मात् परिहार्यार्थे न तुम शोचितुमर्हति। कि जैसे ही व्यक्ति पैदा होता है उसकी मृत्यु निश्चित हो जाती है। तो जिसको आया है उसको जाना निश्चित है, इसके अंदर कोई कुछ नहीं कर सकता। समय, स्थान, परिस्थिति सब कुछ नियत होता है। इस प्रकार से प्री कंसेंट प्रोसेस पेशेंट के मस्तिष्क के लिए होना चाहिए। And unfortunately, why consent is important? Now it is taking different dimensions. अब कुछ इस प्रकार के इंजेक्शन पिछले 20-25 साल से बनने लग गए हैं जिनका हम डॉक्टर्स को नहीं पता, लेकिन वो इंजेक्शन लगाते ही मृत्यु हो जाती है और उसके बाद में शोर शराबा होता है। तो एक नई कंसेंट मेरे एक दोस्त ने मुझे भेजी, वो मैं आपके साथ शेयर कर रहा हूं कि अस्पताल में डॉक्टर साहब ने मेरे मरीज के लिए इंजेक्शन लिखा है। मैंने उस इंजेक्शन को जांच लिया है, ये इंजेक्शन गलत इंजेक्शन नहीं है। मेरे मरीज को इंजेक्शन लगा दिया जाए, उससे कोई भी दुष्प्रभाव होने पर सरकारी डॉक्टर की गलती बताकर हम लोग धरने पर नहीं बैठेंगे, ना ही 50 लाख रुपए और सरकारी नौकरी की मांग करेंगे। So the consent is a document, but it is not just a piece of paper. Consent document is just the tip of iceberg, which is being evolved after a thorough discussion with the patient about everything of his disease and treatment. And patient is given a free will to decide what is to be done. And when after all this discussion, patient decides, and that decision and discussion is reduced into writing, that document is called consent, and that is a very important legal document. Consent broadly is meeting of minds between two or more individuals, meeting of minds between healthcare seeker and healthcare provided, that are you doctors. It is also a type of contract and governed by law of contract, but there is a major difference between the contract, which is governed by Indian Contract Act, and the consent. And the main reason is because the two parties contracting, they are unequal as far as the medical knowledge is concerned. Patient, it is supposed by the courts that he doesn't know much about healthcare and health medical science, and doctors, they know about it. हालांकि आज की तारीख में गूगल और एआई के जमाने में पेशेंट को कई सारी ऐसी चीजें पता होती हैं जिनका हमने कभी नाम भी नहीं सुना हुआ। So what is informed consent? Informed consent means patient should have requisite information to make an informed choice or decision. And the onus of providing the requisite information to the patient is on the treating doctor, that is us. This constitutes the foundation of the consent process. So what is requisite information? The diagnosis, the nature of disease, the gravity of the disease, plan of management which you contemplate, then different alternative options, including no treatment, with their positive and negative points, then the expected benefits, possible and probable risks. Please mute everybody yourself. Then estimate of expenses and estimated length of stay, period of disability, if any, or even mortality. They should, everything should be informed to the patient. And after your information, patient should be given an opportunity to ask questions, and all his queries, his apprehensions, they should be answered. It is only after that that the consent becomes valid. So there are three very important components of the consent which are prerequisite. One is the knowledge. That patient has knowledge means patient is informed. It has to be given by a person who is competent to give it. Competent means the patient should be adult. Who is an adult? Any major patient. Major is decided by Indian Majority Act, which in India is 18 years of age. So 18 साल से ऊपर का कोई भी जो मस्तिष्क से ठीक ठाक है should be sane, should be conscious, and should not be under the influence of alcohol, inebriated or intoxicated, or maybe temporarily under sedation or under anesthesia. Such patient is considered as competent to consent. then it has to be voluntary. Voluntary means it should not be without any force or duress or coercion or pressure or misrepresentation or incentive. Then it is called the free will of the patient or free will of the person who is contracting. So the requirements of the consent document are that it should be in the patient's vernacular. जो लैंग्वेज वो समझता है, हिंदी, मराठी, गुजराती, उर्दू, whatever it is, उसके अंदर इसको समझाने का, लेने का है. It should be procedure specific. There should not be blanket consent which we used to take during our अर्ली रेजिडेंसी, कि हम अपने मरीज का कोई भी ऑपरेशन किसी भी प्रकार की बेहोशी में किसी से भी करवाने की सहमति देते हैं, कोई भी आके दस्तखत कर देता था. दैट इज रॉन्ग. इट हैज टू बी साइंड बाय द पेशेंट हिमसेल्फ इफ पेशेंट इज कॉम्पिटेंट टू साइन. इट हैज टू बी प्रॉपरली ड्राफ्टेड, should be procedure specific, signed by the patient himself, and should be adequately witnessed, preferably by two disinterested witness. कोई थर्ड पार्टी उसको विटनेस करे तो ज्यादा अच्छा रहता है. In case of the patients we come from in this medical tourism or overseas patient, the signature of translator or interpreter should also be taken. Then signatures should be at the right place with their name, date, and relationship, son, husband, spouse, whatever it is. There should not be any blank spaces, and there should not any overwriting. Vital points, it is always a good practice to have written by the patient himself in his own writing and should be duly signed. Then there is a concept of proxy consent, which we will discuss later on, that is power of authorization or power of attorney. It is preferable if we get it at the time of admission. And anesthesia, surgery, blood, as I told you, should be specific, so that consent should be separate. There are certain special consent like high risk admission, high risk surgery, the possibility of risk of death on table, removal of a member of the body, a body organ or a limb wherein there is a permanent damage or permanent sterility is expected when you anticipate multiple admissions or surgeries. Then very important is refusal consent. This is very much applicable in obstetric practice, wherein a gynecologist seeing the fetal distress or some other indication advises for LSCS and patient neither refuses nor agrees, neither signs for the procedure nor signs for the refusal consent. This is a very daily dilemma with the gynecologist. वो बड़े बहाने क्या लगाते हैं, मेरा चाचा आ रहा है, मेरा मामा आ रहा है, इसकी बुआ आ रही है, इसकी दादी आकर के वही डिसाइड करेगी. तो तब तक का वो टाइम है वो निकल जाता है. And unfortunately, if some untoward event happens, then the blame is on the doctor. So in such cases, refusal consent matters a lot. And if the patient refuses to sign, then you put your notes yourself. If there is another consultant available, get his sign, and should be witnessed by other patients who are admitted in the hospital, which should be of your confidence and your own people. Otherwise, your staff can also sign. So then the LAMA consent, that are certain statutory consents, the HIV testing and other things. So consent can be oral or written. It can be implied or explicit. अब आपने बोर्ड लगा रखा है डॉक्टर पवन गोयल, जनरल फिजिशियन, हार्ट स्पेशलिस्ट. दैट मीन्स आपके पास कोई मरीज पढ़ के आया है या सुन के आया है कि डॉक्टर पवन गोयल हैं, भाई वो फिजिशियन है. तो इट इज इम्प्लाइड दैट ही वांट्स टू गेट हिमसेल्फ एग्जामिन्ड. सो दैट इज इम्प्लाइड. जब हिस्ट्री टेकिंग और फिजिकल एग्जामिनेशन आप करते हैं तो पेशेंट रजिस्टर करवा रहा है, इसका मतलब इम्प्लाइड है कि वो कंसेंट उसकी है कि मैं दिखाने के लिए आया हूँ. But the explicit or the express consent has to be specifically sought, in particularly where the intimate physical examinations are there, examination of a female that with the female attendant, any procedure, any surgery, any intervention which has the potential to cause serious discomfort, disability, injury, complication, or even death, or which is likely to cause extra hospitalization, additional surgeries, or additional cost to the patient, that should be expressly obtained. Surgery, friends, without valid consent legally amounts to assault by the doctor on the patient under criminal law and deficiency of service under civil and consumer law. Then the doctor has been given certain therapeutic privileges where the role of consent becomes less. So, in the situations where there are life-threatening conditions or the life-saving procedure required, no consent is required. If a patient is not in a position to give a valid consent, no relative is available, no guardian is available. In cases of notifiable disease, prisoners examination under court order on request by police under section 53(1) CRPC. Now it is 51 Bharatiya Nagrik Nyaya Samhita 2023. No consent is required. Similarly, for examination of a patient, a female candidate under 51(2). So there was very old and almost 40 years old case of Supreme Court on the therapeutic privilege, that is Thomas versus Eliza, wherein patient had protracted course and having life-threatening peritonitis following a perforated appendix. Patient was not in a position to give consent. No relative was available, and the patient died. The Supreme Court held the doctor negligent for not operating on the patient with life-threatening peritonitis, because court held that it was doctor's ethical and legal duty. It is absolute obligation on the part of doctor to treat the patient to best of his ability, and lack of a valid consent is not a constraint in life-threatening situations. The same view was reiterated by the Supreme Court in Pandit Parmanand Katara versus Union of India. Now, I would like to request all the members who want to have their medical legal knowledge, or who want to be aware about the medical knowledge, legal issues, they should read certain important landmark decisions. They should keep their copy, make a summary, take the important points, copy them, have their printouts in their office. So one is Samira Kohli versus Prabha Manchanda, Pandit Parmanand Katara versus Union of India, Jacob Matthews, and such important cases which are used in day-to-day practice. So now the concept of consent from informed consent is being shifting slowly on the real consent after the decision of the British court, Montgomery case, and more autonomy has been given to the patient. So patient has been made an important part of decision making, and patient only can decide if you adequately inform the proper details of the conditions. So the changes and evolution are going to happen. Another is extension of procedure. If during the procedure an additional procedure is deemed necessary, do it if a specific consent has already been taken from the patient beforehand, not during anesthesia, not during surgery. Otherwise, if the proxy has already been appointed by the patient, like if a patient signs that in my behalf, if I am not in a position to consent for any additional procedure or some deviation from the contemplated procedure, so I authorize Mr. X or Y or her husband or son or brother or father or mother or friend, so that if proxy has been already appointed, तो उससे आप साइन लेकर के आगे बढ़ सकते हैं. Otherwise, conclude the procedure, allow the patient to become competent to consent, discuss the details again with him, and perform the procedure if now he or she consents. But for a life of saving procedure, all above can be ignored. So this is that case which I was mentioning, Samira Kohli versus Prabha Manchanda case. अभी आई थिंक टाइम है, हमको 2 केस 3 केस अच्छे से डिस्कस कर लेने चाहिए. दिस इज वन ऑफ देम. सो द फैक्ट्स ऑफ द केस आर that 45-year unmarried female patient presented with menorrhagia and dysmenorrhea. Ultrasound revealed fibroid uterus and large chocolate cyst on right and multiple small chocolate cysts on the left side. Provisional diagnosis of endometriosis was made and details were discussed. Surgery was advised and consent indicated diagnostic and operative laparoscopy. Surgery was performed under general anesthesia. During surgery, an assistant came out of the OT and obtained consent from the patient's mother for hysterectomy. So, total abdominal hysterectomy and bilateral salpingo-oophorectomy was done in addition to the exploration and adhesions. Patient recovered but left the hospital without clearing the bills. Both the parties filed complaint and counter complaint. Patient also filed a complaint in National Consumer Commission because at that time the pecuniary jurisdiction of the state was below 25 lakhs. So 25 lakh was there. So सीधा ये केस नेशनल कमीशन के अंदर गया और नेशनल कमीशन ने इसको डिसमिस कर दिया. So the patient preferred appeal in Supreme Court, which was unfortunately allowed because the doctor took that case very casually. I remember Dr. Kohli always says that doctors are not negligent medically, but most of us are negligent medico-legally. Legally we are very complacent, we just don't care. Arey kya bigdega mera, kya ho jayega. So that attitude we must change and we should take the legal notice and other cases very seriously. We should follow them ourselves, track. We should keep that complete track on the case development and progress. So the allegations of the patient in that Samira Kohli case was that uterus and ovaries were removed unauthorizedly without the consent. She had permitted only diagnostic laparoscopy, but not removal of her genital organs, reproductive organs. So removal of reproductive organs has led to permanent and irreversible physical disability, mental agony, and diminished matrimonial prospects and loss of opportunity to become a mother. During surgery, an assistant had rushed out and told her mother that on account of profuse bleeding, uterus will have to be removed and obtain the signatures on a fresh consent. अब ये जो मित्रों मैंने नीले रंग के फॉन्ट के अंदर जो ये टेक्स्ट लिखा है इसमें इसको आप ध्यान से देखना 3 जगह पे आएगा गलती कहाँ हुई है. सो उन्होंने कहा कि ब्लीडिंग हुई है. Later, when protested for removal of uterus, the doctor rudely stated that in view of her age, conception was not possible. So removal of these organs was immaterial. So the defense was that details about the disease and plan of management was discussed. And at surgery, extensive disease was found. Therefore, TH and BSO was done. And here, that allegation was defended that there was no excessive bleeding as alleged. Had they taken the clue and had they taken this defense, but that as patient alleged that because of excessive bleeding, yes, excessive bleeding is a life-saving procedure, is removal of uterus. So the case could have taken a different turn. But anyway, so with the surgery, patient was relieved of her symptoms and also the possible complications of progressive disease because there were already adhesions with bladder and the large bowel, and due to her age and the disease of endometriosis, she had no chances of conception, even if her organs were preserved. So this was the defense. So Supreme Court what observed is very startling. Consent for surgery means permission of the patient to carry out a procedure on his body. Surgeon cannot go beyond what has been consented to. A valid consent is given voluntarily by a person competent to give it and gives it by application of mind after knowing the relevant details. And the duty of doctor is to provide the adequate level of information, requisite information and relevant details so that patient can decide. Extension of a procedure beyond what has been consented to can be performed only under the principle of necessity. This occurs when there is immediate or imminent threat to life, as it would be unreasonable to delay the procedure till patient becomes conscious. In all other situations, surgeons should close the operation, allow the patient to come out of anesthesia, discuss, and again, if patient permits, go for surgery. Convenience to perform, sparing the patient of additional surgery or cost, or being beneficial to the patient are no acceptable reasons for doing anything beyond what has been consented to. And the adequate information which I mentioned, this is from the Supreme Court guideline only, these you have to provide. And consent given for diagnostic procedure cannot be considered as a consent for therapeutic treatment without specifying the therapeutic options contemplated. So in the present case, the Supreme Court held that operation notes indicate no emergency or life-threatening situation. Unfortunately, the documentation in this case was horrible. There was, different things on OPD paper, on indoor paper, on consent and operative notes. They were not in sync with each other. So that reflected very poor medical record. Laparotomy is only opening of abdomen. Contentions regarding different forms of treatment for endometriosis are acceptable, but it is the patient who has to choose what she wants. This patient was neither minor nor mentally challenged. She was temporarily incapacitated due to anesthesia, and there was no life-threatening situation necessitating such extensive surgery. So the doctor should have not done it, should have allowed the patient to come out of anesthesia. So, and moreover, Supreme Court observed that no other person, including mother, can give a valid consent when the patient himself is an adult and competent to give consent. So the appeal was allowed. Compensation of just 25,000 plus interest at 10% with cost of 5,000 was allowed, was awarded. The court was lenient on awarding the compensation because though the consent was not valid, the patient was relieved of her disease, and the surgeon, in good faith, though erroneously, had considered mother's consent to be valid. Then this is another important case law which I think we can discuss because we still have little time. This was the first case of highest compensation before that Kunal Saha case. The total compensation was around 1.7 or 1.8 CR. So patient, a young engineer presented with recurrent fever. This is NIMS versus Prasanth Dhananka. Patient presented with recurrent fever, weight loss, loss of appetite. He was found to have a mass in left hemithorax with erosion of second to fourth rib. Multiple US guided and CT guided FNACs were inconclusive. Hence, excision biopsy was advised and referred to CT surgeon. The surgeon excised the tumor and the fourth rib, which resulted into paraplegia. At the concluding stage of the operation, a neurosurgeon was called who noted that erosion of ribs and multiple bodies. So the allegations were that adequate pre-op evaluation was not done, particularly MR, myelogram. Request for deferment of surgery not granted. Possibility of paraplegia was never spelled out before surgery. Neurosurgeon should have been involved right at the start of the management plan. Consent was for excision biopsy, which is an exploratory procedure, but surgeon unauthorizedly removed the whole tumor and the fourth rib, destroying the intercostal blood vessels, causing ischemic myelopathy and paraplegia. This case was prepared by the patient himself, who was an engineer. He studied extensively about the medical issues, about the blood supply, about the causes of paraplegia and everything, and he presented it himself. Development of bed sore, frequent and necessary exposure to X-rays reflected deficiency of services and poor post-op care also. So the defense was that fever, loss of weight, and all these symptoms were suggesting that the lesion could be malignant. Repeated NFNACs were negative, so excision biopsy was the next best option. At surgery, frozen section was done, which revealed that the disease is though benign, but since it has involved the ribs and vertebral bodies, so the removal is necessary to prevent the further damage. Neurosurgical help was needed only when it was noticed during surgery that intraspinal extension of the tumor has taken place. All necessary pre-op investigations were done and there was no negligence. But Supreme Court what observed was that pre-op record mentions a mass in left chest with erosion of ribs. So it cannot be accepted that the erosion of ribs and vertebrae were noted during surgery only, because it was already there. MR and myelography, why it was not done, has not been adequately explained in the reply. Not involving a neurosurgeon in planning and conduct of surgery was a deficiency of surgery, which was not adequately explained. His involvement could have prevented the occurrence of paraplegia. Regarding consent, Supreme Court accepted that though patient was reluctant, but since they arranged blood, that means there was some consent. But there is no consent document on record. This was very unfortunate. निम्स जैसे इंस्टीट्यूट के अंदर ये लास्ट तक सुप्रीम कोर्ट के बार बार कहने के बाद भी वो कंसेंट पेपर कोर्ट में प्रोड्यूस नहीं कर पाए. The medical records were also submitted after repeated directions of the court, and all these things, they raised a presumption against the doctors. Consent taken for excision biopsy cannot be accepted as implied consent for therapeutic procedure except under life-threatening situations. So it is clear that the bright career of an educated engineer has been cut short, besides loss of health and disability associated with it. And all this has occurred on account of negligence and deficiency of service on the part of doctors of the respondent hospital. So compensation of the charges incurred, prospective charges for physiotherapy, nutrition, driver cum attendant, loss of work for an estimated active life of another 30 years, damages on account of mental trauma, they were calculated to be 1 crore plus interest at the rate of 6% was awarded by Honorable Supreme Court. There is another court case from Allahabad High Court in Dinesh Kumar Singh, in an appeal filed by Dr. Muhammad Azam Hassin and Dr. Adil, seeking quashing of proceedings under Section 304 AIPC, which were pending in the additional CGM code, that when the patient and family members give consent for operation, they give consent to bear its consequences too. Now, this is another very important, I'll finish in 2-3 minutes. SK Jhunjhunwala versus Dhanwanti Kumar. This was decided by Supreme Court in 2018. This is almost similar case as of Prabha, Manchanda and Samira, Kohli. But the difference is that this case was beautifully defended and well fought with all evidences and with good medical record. And wherein the two things which were citations in that discussion in the court from the other cases was that the subject of negligence in the context of medical profession necessarily calls for a treatment with a difference, very important statement. And suffering of ailment by the patient of surgery is one thing, or it may be due to myriad of reasons known in medical jurisprudence. मतलब कहने का है कि ऑपरेशन के बाद मरीज कुछ भी शिकायत कर दे, तो it is not necessary that they are the consequences of the surgery. So this complaint was filed in State Commission of West Bengal in 97, was dismissed. Then the complaint named challenge in National Commission. National Commission awarded compensation of 2 lakh. Surgeon challenged by special leave petition in Supreme Court in 2009, and after 9 years, the doctor was relieved by Supreme Court in 2018. So very brief fact is, patient had gallbladder calculi. He consulted his family doctor, who referred him to Dr. Jhunjhunwala, who was a senior surgeon. Dr. Jhunjhunwala advised him, he had surgery, patient got admitted, and laparoscopic cholecystectomy consent was taken. Patient was posted for lap chole, but because of extensive adhesions in the Kellogg's triangle, the doctor came out of the operation theater, explained himself to the husband of the patient, obtained the fresh consent for open procedure, which was a very wise decision to convert from laparoscopy to open. The doctor completed the procedure, patient recovered completely, was discharged, and after about a week, and patient did not complain anything at that time. But later on, patient was subjected to another procedure in Gangaram Hospital, Delhi, for ERCP and removal of CBD stones. So the allegations were that patient had given consent for lab Kohli, but the surgeon performed open surgery without consent. Surgery was not successful as she suffered for several days with dysentery, loss of appetite, reduction of weight, jaundice, and all these things. Stones had passed into CBD and she had to undergo another surgery in another hospital. The defense was that after due examination, lab Kohli was advised correctly. After starting the operation, the surgeon noticed swelling, inflammation, and adhesions in the gallbladder fossa, which necessitated conversion to open cholecystectomy. He came out, disclosed the findings to the husband, and he agreed and gave another consent. The surgeon completed surgery. The patient recovered and was discharged. All protocols and all guidelines were followed. All precautions were taken during surgery and post of care was taken. There was no negligence or deficiency of surgery. Supreme Court decided that there was no negligence of deficiency or the deficiency in services by the surgeon who treated the complainant, and Supreme Court uphold the state commission decision and set aside the national commission decision of 2 lakh compensation. So the basis of decision I would like to tell you was the Bolam test. So test of negligence is the standard of ordinary skilled man exercising and professing to have that skill and not the top man in the field. Means जो average surgeon है उसकी skill will be the yardstick to measure the skill of the operating surgeon. A surgeon cannot guarantee the result of surgery. The only guarantee that he can give is that he possesses requisite skill and he would exercise the skill with reasonable competence. He can be held negligent only on 2 accounts: that if he does not possess the requisite skill, or if he does not exercise the reasonable competence or due diligence which he possesses. So assessment has to be made on the basis of knowledge available at that time of incident. अब आज कोई पुराना केस 1980 का 90 का हो तो वो केस को आप आज की तारीख में जो प्रोसीजर या ट्रीटमेंट स्टैंडर्ड अवेलेबल है उससे कंपेयर नहीं कर सकते. दिस वाज वेरी इंपॉर्टेंट फाइंडिंग ऑफ द सुप्रीम कोर्ट. That time, what was the prevailing practice, which was adopted by majority of the professionals or professional bodies, that will be kept in mind. Doctor cannot be held liable simply because things went wrong for some mischance or an error of judgment or choosing one course of treatment in preference to another. He will be held negligent only if his conduct falls below the standards of a reasonably competent practitioner in that particular specialty. So in the present case, Supreme Court held, it is not in dispute that doctor is professionally qualified. He was FRCS, he practiced in London, and then he shifted to Kolkata when this patient was treated by him. So he possessed the requisite knowledge and skills. It is not in dispute that he proceeded with laparoscopic cholecystectomy as planned, and on finding swelling, inflammation, adhesions, he decided to convert to open surgery. Regarding the consent, the Supreme Court stated that clause 4 of the consent form, उन्होंने लिख रखा था उसके अंदर कि इसकी जरूरत पड़ सकती है, patient might need or the surgeon might have to convert in cases of problems in that area. उस टाइम होती भी थी, बड़ा standard consent था. The husband gave the consent. The complainant has not denied the presence of husband. This being the natural conduct of surgeon under those circumstances, the consent to perform open cholecystectomy is correctly made and the conversion to open cannot be called unauthorized act by the surgeon. The complainant never raised this issue before approaching the court. Natural conduct of a person would have been to raise this issue with the hospital during or after the hospitalization, which the patient never mentioned. Regarding CBD stone, Supreme Court held that complainant has failed to prove that the stones in CBD were the stones left behind during the primary surgery. She has also failed to prove that symptoms in the post-operative period were due to improper surgery. Then there is no direct nexus between the two. This is very important. In our first lecture, which was given by Ashish, he mentioned that it has to have a very direct link with the negligence, with the act which led to that particular injury or complication. So human body is a complex machine. Medical negligence has to be treated with the difference, as the reasons for a mishap during treatment may be very complex. Human body and its working is highly complex, and allegations sometimes may be misplaced. So the blame on the doctors has to be attributed with caution. So to conclude, friends, our relationship with the patient is more of a contractual nature rather than fiduciary. Patients today are much better informed of their rights and are not willing to accept adverse outcomes as the will of God. Society in general and consumer courts in particular have a prejudice in favor of the patient, that is consumer, even though the courts try to balance. अब जिसका नाम ही है कंज्यूमर प्रोटेक्शन एक्ट है, वो नेचुरली बायस रहेगा कंज्यूमर के लिए. So we need to take all aspect of consent seriously. Proper communication and proper medical records are the most important measures besides proper management to prevent litigation. Proper documentary evidence, expert evidence, and a dedicated lawyer who has the knowledge of medicine and law both, who is not very senior, who is available to you with your discussion, they are very important measures for succeeding in such litigations. Friends, when Dr. Ritu Jain was in, Gynae secretary, society secretary, that time gynecologists, they devised different consent for different procedures. I raised this issue in our association, and we tried to make and laparoscopic consent, cholecystectomy consent, we devised a specific consent. So the associations, they need to take lead to formulate such consents and a uniform consent, because that the Supreme Court decision on that Delhi Court decision on consent regarding RG Stone Clinic was not a good decision, and it was challenged in Supreme Court, which is still pending. But there is no bar on taking consent on a pre-printed format, but it is always a good practice to get all these important vital aspect of that treatment under on the consent paper in patient's handwriting. So with this, I would like to finish. Thank you so very much. I think I did not take much time, Dr. Pawan.
Thank you, sir. Wonderful, wonderful presentation, and very well timed also, sir.
Thank
Hello.
you, Dr. Suresh.
Thank you, sir. Thank you.
It was
Thank you,
very
sir.
nice. It was excellent, as usual, from Dr. Suresh. Yeah, I would like to add one thing in this, added to that. In the Thomas versus Elisa case, okay, and doctor lost the case because he did not operate, even though it was emergency. But if we have taken a dissent consent, patient refused for the consent, probably it would have been reversed.
Yes,
One more thing. Yeah. And the other one is in Samira Kohli case. And to what an extent you can reveal to the patient risks comprising of. So if there are remote risks, maybe 1 or 2%, which should not be brought to the notice of the patients are related, because they would have frightened and they would not permit for surgery. If there are substantial risk, maybe more than 10%, definitely we may have to bring to the notice. And after this case, what I found was, you have advised for the laparoscopic surgery, and you don't know intraoperatively, you may have to revert it to the open. In this case, if you are anticipating that one, a common consent can be taken where it may be contemplated. For example, anytime it can be turned out, or anytime it can be an extension of surgery. That kind of probably that kind of a consent still holds good, I believe.
very correct, sir. Yeah, that's what I was telling. We have devised and we have come out with a universal consent for lab Kohli, and it contains that provision that in cases of difficulty, the doctor might have to convert to the open surgery. Correct. Very right. Thank you,
Dr.
sir.
Suresh, good evening.
Namaskar. Namaskar.
Namaskar, boss. ऐसे है कि I would also like to add 1 or 2 things.
Please, please. You are expert.
Well, I'm expert. I'm just a small. सबसे पहले तो I should just inform the group that me and Dr. Kohli have already registered our company, and KN Medico-Legal support, we have started it, and we are providing support to the doctors and the hospitals. And one thing is,
Congratulations.
thank you. One thing is that a very important part of consent is how much of complications, what the sir was saying is, for this, there are two principles. If you go through the literature, one is called prudent doctor
Prudent
principle.
patient and prudent
A
doctor.
prudent doctor. So prudent
Yeah.
doctor principle, the doctor decides what he wants to tell the patients, depending on his uh, qualification, his intellectual. That part, that is done in India and in UK. But in US, it is a prudent patient principle where the patient decides what information he wants from the doctor. If you actually see the consent forms of the US for a surgery, they are a booklet of 15, 20 pages. And every doctor has to maintain his record that how many surgeries he have done, what was the complication rate. So the patient can ask you, Dr. Vashish, how many cholecystectomies have you done in your lifetime? What was your complication rate? What was your death rate? And you are obliged to give that information to patient. In
Correct.
India also, now in corporate hospitals also, patient, I don't know, they go through the net or whatever. This prudent patient principle is being followed in India also. So every doctor has to keep a record of all his surgeries, and the patient will be asking you, sir, how many surgeries of this type you have done? What was your complication rate? What was your death rate? So that is one thing I have to tell you.
Very right.
All days
If
are gone.
sorry,
Another thing I want to, just small thing is, practical thing is, when we take the consent for surgery, we write the name of the doctor. I consent to, I give consent to get operated by Dr. Vashisht. Okay. Never in our consent, if you, I don't know, now they have done corporate hospital, after I visited one of them, they have started doing it. Why don't we take the consent for anesthesia? You see, when we write the name of the anesthesia surgeon, why we are hesitant to write the name of the anesthetist, and the let patient be part of the decision. You should know that so and so will be my anesthetist. Corporate hospital may be doing it, but smaller hospitals don't do it. They just write, I give consent for surgery by Dr. Suresh Vasistha. My suggestion is, if you see the complications on the table, half of them will be due to anesthesia only. But patient doesn't know the name of the anesthetist at all. So my suggestion is, when you take a consent for surgery, if you have a permanent anesthetist or somebody who you know who will be giving anesthesia, please write his name also in the consent, that I agree to be given anesthesia by doctor so and so that he's part of the decision making regarding anesthesia also. So these 2 points, I think I have made clear.
you are very right, Sanjay. And if you remember, I mentioned the concept of real consent. But in India and UK also, now they are, after that Montgomery case, no, that the concept has changed in UK also. And now they are also shifting, because they have also said that it is the patient's autonomy. So they have made the patient the axis of that consent process, which I mentioned. And the same is already being practiced in America. That is what a real consent.
Yes.
That's what I
Anesthesia part, I'm
and
very
as
sure.
regarding your another
I think
comment,
Dr.
that is
Sanjay,
also very good, which I mentioned in my presentation also, that we have to
Yeah.
seek separate consent for
yes,
separate consent for anesthesia. All
yes.
NABH hospitals, they follow this practice now, and we are following. But in case of corporate hospital, suppose this is my unit, I'm Dr. Suresh Vasistha doesn't mean Dr. Suresh Vasistha, may mean my associate Dr. Sanjay Narula, my associate Manoj Agarwal, my associate Naresh Sharma, or whosoever is with me. So the consent has to be little different, but I do agree with you. And I mention always that we should have different consent for surgery, different consent for anesthesia. Very good, very good.
No, I think like in, of course, we are having a very small setup, but still, for years together, we are taking this anesthesia consent separately from this surgery. And
Yes.
in that is the name of anesthetic is already always mentioned. So this is there. But I think it's very prudent that we should take two
तुम बैठे कहाँ हो संजय?
consent, definitely.
मैं घर पे हूँ, थोड़ा
मैं देख रहा हूँ,
लैपटॉप
बैकग्राउंड देख रहा हूँ तुम्हारी.
मेरे बाहर दिखे, कोई बात नहीं, डोंट वरी, मैं इस तरफ आ जाता हूँ. आई एम सिटिंग इन माय ड्राइंग रूम. ठीक है, बहुत बढ़िया
Dr. Suresh, it was an excellent talk. Okay, Dr. Suresh.
Thank
Yeah,
you,
most
sir.
of the things when very simple language are covered. Yeah.
Any other question or comment from any other attendees?
Good evening.
Good evening, Dr. Pramila.
Dr. Pramila Malik here. Dr. Vashisth, excellent talk by you.
Thank you.
I just wanted to add one thing that now we have from Foxy uniform consent Foxy for all different procedures.
36,
Each and
36
every
onwards.
procedure for a normal delivery, for cesarean, for cervical encerclage, for hysterectomy, every this thing we have been provided by the Foxy,
I'm
and
aware,
we
madam.
can download it from the Foxy website, and even anesthesia consent is there in that. In that consent, the thing is ki they are not only taking the, it's not only a consent form, they are giving each and every even minor to all minor details of the procedure and all the complications, remote complications also which can be present. You can give that leaflet to the patient. Suppose the patient, there's a consent for vaginal delivery, you can give the patient that leaflet at around 35-36 weeks to read it at home. The patient can go through that, and then you can just after 1 week you can tell the patient that have you understood everything. If you have any problem, if you have not been able to understand, or if you don't agree, you just let us know. Then the patient and the husband or attendant, they sign it that we have read it and we understand everything. And then there is a separate paper for the consent when the patient gets admitted. Then the consent is separately taken on that paper. It is in that leaflet only. I think that
Very
is
correct.
very good.
You are
And
absolutely right, Dr. Promila, and I am aware of that. And I always emphasize that I know about the different consent, and it's a very good move.
yeah,
And I would like to add a small thing here that I am also a permanent board member of Institute of Medicine and Law, which has done extensive research and work in
yeah,
consent. I'll share the link. Every year they revise that consent process.
yeah.
And since 2012, I'm associated. Dr. Kohli was also with me during the Ahmedabad.
It's a very good. It's a very good
Yeah.
boon for our gynecologists and obstetricians. It's
Yes,
very
yes,
much in detail, and you
very
can
right.
just take it and then get it printed on your hospital name. In the top, you can write your hospital's name, and the language remains the same.
But still, I would like to add that you have some space in that format. But suppose patient is hypertensive, patient is
Yeah,
diabetic,
yeah.
patient is on
That we add.
antiplatelets.
That
So
we.
that that you mention in patient's handwriting, or you mention get it signed separately. That
Yeah,
gives
yeah.
it a more
If there is any
authentic.
high risk for the either for the baby or the mother, we
Whatever.
do it in hand. This thing, get it handwritten.
Very right.
Just that. Yes. Thank you. It was an excellent presentation.
Thank you, ma'am. Thank you.
I think
Let me make a small comment. It
Sir,
was a very wonderful presentation by Dr. Vashisth.
all your blessings.
See, for so many years, we've been battling with Consumer Protection Act. We have been talking about medical records and consent. But still, even today, in many hospitals, even in some of the corporate hospitals, we often see that the consent has not been taken properly. There are blank spaces. There are the patient's name gives the signature of the witness, and witness space gives the signature of the patient, and so on and so forth. So I personally feel that the consent should always be signed by the surgeon himself, the treating physician, the treating surgeon, and he should make it a point, because many a times we see that the consent is delegated to the junior most resident or even to a nurse, and the junior most person goes and takes the signatures, and the matter finishes. And the next time they see that the consent has not been taken properly is when they receive a legal notice. So, as a routine, every consent, when it is taken by the nurse or the doctor, should be signed by the surgeon. It also means that the surgeon is has explained the details, has provided the requisite information to the patient before taking the signatures. And secondly, he will have a look at any deficiencies in the consent document. And the person who has taken the consent will also be vigilant and cautious, because he knows that the surgeon is going to sign and he'll catch the gaps. So I think we must take a lot of, as Dr. Vishesh said, 60-65% cases of litigations and medical negligence, they revolve around medical records and consent. So if we are able to have perfection in this area, we have solved 60-65% of the problem. So I think we should be more realistic in consent. One small little thing which was touched by Dr. Vishisht also in NIMS case, the hospital did not present the consent document. See, they had all along been arguing that they had taken the consent. They had taken the consent for the therapeutic procedure also, not only the biopsy. But since they could not produce the document, this doctrine is called adverse inference. If there is some proof lying with you and you are not willing to submit it to the court, that means you're hiding something. So the presumption is that you're hiding something. So this is called rule of adverse inference. So the adverse inference is taken.
Correct,
So
sir.
it was a very good discussion, good presentation. Congratulations to Dr. Vishist.
Thank you, sir. Thanks for the pulse of wisdom.
A lot of deviation has occurred for the last half an hour. Baki Suresh Vasistha is best to decide. And the Pawan
No,
Goyal is best.
Pawan.
Pawan is best to decide. I think we are deviating too much. And
Yeah.
also, please request is, let's not name the doctors in the meetings. We are, especially if we are talking negative about them. So Baki rest is all yours. Thank you. Pawan to decide.
Thank you, sir. Thank you. And
Okay.
now I would request Dr. Dhirendra Soni, sir, our secretary, for the closing remarks.
Yes, sir. Excellent presentation by Dr. Suresh Vasistha. सबको जरूरत थी, आई थिंक इसकी सबको है, आइडिया है, पर बार बार रिफ्रेश होते रहना चाहिए ताकि हम गलती ना करें. थैंक यू डॉक्टर सुरेश, थैंक यू ऑल द participants, thank you all the to join. Let's meet again next week. Thank you.
Thank you.
Okay,
Thank you.
good night.
Good night.
night.
And
Excellent,
wish
thank
you
you.
happy Diwali, all of you.
Yeah, happy Diwali.
Before
Happy
next
Diwali.
week.
Happy Diwali once again.
Thank you. Happy Diwali.
And the academic fiesta on 21st stands suspended because after Diwali, nobody is in the mood of academic fiesta. So
Okay.
we'll meet again on 28th.
28th. Okay. ठीक है, sir. Okay,
Thank
good
you, sir.
night.
Thank
Good
you.
night, sir.
Good night. Good night, everybody.
Good night, Dr. Pawan. Good night. Okay.
Good night, sir. Good night.